Welcome back to Mental Breakdown. I'm your host, Minon Maier, and today we are diving into a topic that is critical and can often be overlooked: the boundaries of the therapeutic process. Often, when people think about therapy, they think about it as a universal cure-all or maybe a catalyst for change, but the truth is more nuanced than that. Just like any clinical intervention, therapy has contraindications, meaning specific circumstances where certain types of work might not be effective or even safe at a given time. Today, I'm joined by Adia Williams, licensed associate marriage and family therapist, and we are going to pull back the curtain on how we ensure that therapy is actually productive. We will be discussing the specific red flags and environmental factors that can stall progress for couples and families in therapy, moving us past unspoken expectations and into real conversations about clinical safety. We will discuss what these red flags are, what to do with them, and when therapy is not clinically appropriate. Whether you're a practitioner or maybe somebody who is looking for support or therapy curious, understanding these barriers is key to ensuring that the space we create is healthy. Let's get into it.
Well, Adia and I are here today. We are going to be chatting about something that has been really just a big theme, I think, in our sessions recently and for the practice, but contraindications for therapy. So for anybody listening, a contraindication would be something that tells us that therapy is not a good option. So it's something that is telling us that this client or this presenting concern might not be appropriate for therapy. Is there anything that you would add to that, Adia? Because I feel like I gave a very
No, I think that's great. I think the only thing I would add is not necessarily like contraindication in an absolute rigid sense, but there are
Mhm.
definitely situations where traditional therapy is not appropriate or effective in
Yeah,
maybe that form. So, taking in mind like readiness, safetyness. I'm making words up.
I love
Readiness
it.
and like the appropriateness of
Yeah.
therapy or said intervention. Not like this person can't ever do therapy, but given this person,
But like right now.
yeah.
Yeah.
I think that's the
And
only
well, and I love that because what you're talking about is it's kind of fluid depending
yeah.
on what's coming into therapy. And I think also taking into account what is your therapist trained in. And
Mhm.
there might be a contraindication or a reason that therapy isn't clinically appropriate at this time that could have nothing to do with the client. It could have everything to
Yeah,
do with the therapist's level of training, skills, things like that. But I think what
totally.
we've been seeing a lot lately is more of like client presenting concerns coming in or openness, willingness, safety, things like that that have been blocking the therapeutic process.
Yeah, totally. Yeah, and it's not like client is bad or therapy is bad. More so at this time in this format, this might not be clinically helpful or appropriate and could actually reinforce harm. Yeah.
Yeah. And so I think maybe we'll just start with like couples because
Yeah.
I feel like we do more work as a practice with individuals working on like trauma, relationship issues, general life stressors, and then couples relationships. And
Yeah.
so in a couples relationship, a lot of times couples are coming in with problems. Typically couples aren't coming in because they're like, our life is great and we just really want to improve on our relationship. Usually there's been a disconnection, a betrayal, a crisis, something that's
Yeah.
basically brought them to therapy at this point. And
Mhm.
so I think something I've been seeing more and more lately, and I'm curious your experiences, but has been the impact of substance abuse and addiction in a
Mm.
relationship and how that has been more prevalent recently with some people where, the way that I talk about it is it's a competing attachment. And so whether it's alcohol, whether it's marijuana, whether it's something a little bit harder, it is then taking the attachment away from your partner and it's putting it on the substance, especially if the partner has an issue with, let's say, alcohol, for example. If the partner's like, I don't like it when my partner drinks, but the partner continues to drink. And so I will tell clients, this is a competing attachment. And if you're not willing to do something about that, we're going to hit a wall in therapy. And at this point, there's not going to be a whole lot else that we're going to be able to do to move forward and heal and repair.
Yeah, I like the way you described that of like we're gonna hit a wall. Like there is work that we can do, sometimes, I mean, my brain goes to, like, active addiction where
Yeah,
there's like a there is something bigger here happening, and that doesn't always surface right away, I think, and
it
maybe
does not.
sometimes time that becomes more apparent, and it's like, okay, as a therapist, it's like we're kind of constantly assessing all these different areas, and if there is this, like, wall that's being hit and this thing comes out that there is active addiction happening in, whether that's substance use in the relationship, if that isn't addressed, then we will literally keep hitting this wall. Like, we can
Yeah,
do some of the work, but it's not going to be this like long lasting change. And then, I mean, I think that goes also into like scope of practice and scope of competence stuff. It's like, I am not specialized in any like addiction specific, substance addiction specific training. And so making sure that the client also has that outside referral and support
yeah,
that is appropriate and can actually support them and help them in that way.
yeah. Well, and I love that you said that about, I don't have the training and experience, and I have a ton of training in substance abuse because when my former life as a therapist pre licensure was working a lot in the substance abuse field. So, working with mandated clients that maybe were leaving prison or jail, mandated to
Yeah.
do substance abuse groups, working with kids on probation, working with clients who had a DCS complaint where there's been substance abuse. So it was a very active part of my former
Yeah.
therapy life. But I don't feel competent in treating addiction if it's active and ongoing, especially if, like maybe the partner that has the addiction or maybe is abusing the drug or alcohol regularly. I don't have the active training and experience to, be up on the latest interventions or safety planning or warning signs or even like the latest drug trends that are happening in America. Where, 10 years ago, I could have told you all the things, but not anymore. And so I think you're right, like making sure that they do have a specialist that is properly trained and competent to work with that, even if that means like we're going to keep doing couples therapy for a little bit, but I want you to do individual work with this person on the
Yeah.
addiction or on the abuse. And let's make sure we have a signed release of information so that we can coordinate with the addiction counselor. And
Yeah.
that might be a step before we're like, nope, you're not clinically appropriate for therapy. It's like we're
Totally.
going to
Yeah.
try to
No, I'm so happy.
bridge things in. Yeah.
Yeah, I'm so happy you said that because it's not always, and I mean, I feel like it looks different just depending on the situation, the
For
client, the
sure.
prevention concern, the addiction, the level, all that kind of stuff. But I think that is always the goal. It's like, we're not trying to like get rid of clients, but it's like, okay, when this thing comes up, how can like, how can we best support you? And sometimes that literally means there needs to be a higher level of care. And we can
Yeah.
absolutely, and we encourage that like release of information so that we can collaborate and coordinate and make everything cohesive and everybody on the same page. Yeah, if it's just not addressed at all and it's actively happening, it can definitely be a barrier to therapy. And I mean, something that just popped into my mind is like that emotional dysregulation piece with active addiction and how that could show up and be really
Yeah.
harmful in like a couples therapy setting where you are actually literally kind of moving into this act, you're kind of things are getting activated. You're talking about hard things. It's like couples therapy is not this like all sunshine and rainbows process. Like not yeah, to put it lightly. And so if there is something else contributing to emotional distress and dysregulation, that could also be like really problematic.
I love that you said that. And I think the flip side of that too is a lot of times when people use, it's to numb out, right? It's because they
Yeah.
can't deal with the emotional discomfort or anything like that. They don't have that window of tolerance. And so, yes, couples therapy can be very triggering because we are talking about really hard topics that typically cause disconnection, conflict in the relationship. And so we're doing it in a much more structured, effective way, but we're still tapping into those really deep, uncomfortable emotions. And so the person might be dysregulated in the session, or it might actually be a trigger for them to go use more, depending
Yeah.
on where they're at. And so it's almost like two sides of the same coin. But again, that's where we would want an addiction specialist and addiction counselor involved in order to tell us, this is actually making it worse. Here's what we're recommending, or,
Yeah.
here's what might be more helpful, or different things like that.
Yeah. No, that's a really, really great point. I think something that came to my mind as you were talking about that was this like after session process when you were talking about, say, couples therapy was really triggering,
Mhm.
client leave. It's like, okay, under a lot of emotional distress, and now, active addiction is happening and wanting to use as that numbing out or like that release.
Yeah.
My brain kind of goes to, depending on the situation, like say active abuse and domestic violence, things like that, psychological abuse, emotional,
Yeah.
are also present in this relational dynamic. That addiction side can also be an additional problem there, where it's like, we see you for this finite amount of time. I don't know whether that's like once a week, once every couple weeks.
Hmm.
There's a lot that can happen outside of session. And so that's another thing that we always are assessing for and keeping in mind is like safety. Does having couples therapy increase danger risks and ongoing abuse? My brain goes to like retaliation if things that are said in session
Yeah.
are difficult. Um, Manipulation, things like that.
Well, for sure. And I think that would apply for couples and families. That would be a contraindication and addiction as well. But especially, let's take addiction or substance abuse out of the picture as a contraindication. And let's just talk about the safety concerns that you talked about. That is also something, like you said, that we have to be really aware of and making sure that we're not setting the clients up for more harm to happen. And so, if there is physical abuse, psychological abuse, financial abuse, isolation, things like that, like we might say this isn't appropriate right now for us to do because therapy is actually going to cause more harm as a
Oh,
couple or as a family. So individual therapy might be a better option for each partner.
yeah, well, absolutely. And it becomes the priority because I think in couples and families going in, it's like, okay, as a therapist, you want to be
Hmm.
neutral, but safety overrides that. Safety
Yeah.
overrides neutrality 100% of the time. And if there is like genuinely a safety concern, that has to come first.
Yeah.
And so, yeah, I love that you said like maybe that is pausing couples and we need to do individual and getting both people in individual
Hmm.
therapy and having that resource or specialized services
Yeah.
um, before the couples therapy relational dynamic is addressed.
And I've done that where I've said, you guys need to go to your individual work, and I need the okay from the individual therapist that couples therapy is safe to resume. And, I want a signed release of information. Here's what this person should be working on based on what came up. Here's what this person should be working on just from a couples lens because of the safety concerns, you
Mhm.
know?
Yeah, and I think as a therapist, trusting your gut with some of those feelings in those
Yeah.
sessions and assessments, and I think a lot of times in couples therapy, we will do like an intake
Mhm.
all together and then meet with individual partners for that following session or,
Yeah.
sometime in the beginning-ish of the process.
Yeah.
Just as part of that like comprehensive assessment. And I think just really trusting your gut when you are getting a feeling about something and exploring it further. I feel like that is doing your due diligence as a therapist.
Yeah. And I think for anybody listening to this that maybe was in a therapy session and there were some sort of contraindication where maybe there was like a safety concern or addiction or something like that, especially with like, let's go back to domestic violence. So the psychological abuse, the emotional abuse, even with addiction, you said it at the beginning of what's the openness and willingness to even talk about it? Because if let's say the perpetrator or the person that's actively using or actively hurting their partner, if they're open to talking about it, saying, I don't like this, I want to stop drinking, or I know that this is a problem. Here's what I'm trying to work on. Maybe they're not perfect, but there's this accountability of, yeah, this is a problem and I see it. And here's what I'm willing to do. Here's what I'm working on. I'm meeting with a
Yeah.
psychiatrist. I'm working with an individual therapist. Here are the coping skills. Then we can give a little bit of wiggle room, but we still, as therapists, might be trusting our gut, saying, okay, this maybe is not a good topic for us to talk about today, given the dysregulation that is still there from the person who is the safety concern.
But one of the things that comes to my mind, so we talked about like active addiction, which I feel like is a big
Yeah.
one, abuse, and in the couples context, something that I feel like would be under that umbrella is ongoing active affairs. And that's
Yes.
kind of tricky because couples dealing with an emotional relational rupture like an affair come to couples therapy? Absolutely.
Absolutely.
Yes, absolutely. That is like, yes, come to couples therapy for that. And if it's something that is actively happening, it is pretty impossible to build a safe emotionally safe space to really do the couples therapy work.
Yeah.
I'm curious your thoughts on that. Like, I feel like that, like the active, this is still continuing to happen. And there's things as a therapist, like we might recommend, like, okay, we need to do, if we're going to do couples therapy, there needs to be a disclosure session, planned out, thought out disclosure session where we just kind of like address the elephant in the room head on. Yeah. I'm
Yep.
curious thoughts on that when like affairs are in the picture.
Yeah. And I love what you differentiated because there can be a history of an infidelity.
Yeah.
That doesn't disqualify couples or make them ineligible to come in and do couples therapy. If there is an active ongoing affair, so let's say one partner is like, hey, I'm sleeping with this other person. I'm not cutting off the relationship, or maybe there's an emotional affair. I'm not going to stop talking to this person. Kind of like with active addiction, like we're going to hit a wall. Because again, it's a competing attachment. And so, how do you repair the secure attachment between you and your partner when there's this third person or thing that's causing more of a rupture every single time?
Totally. It's like, I kind of think of it like we will just keep hitting this wall, like couple steps
Yes.
forward, many steps back. It's like we can do some of the work, but if this is still happening, if there is still this elephant in the room and maybe we're not talking about it directly, maybe we are, maybe both people are fully aware of this situation, but it is actively happening. That's just not a framework that we can create safety in and trust and rebuilding. And I think it can be really scary for couples with, that mention of like, let's do a full disclosure and
Hmm.
like get it all out there. And I totally understand that where there's like fear in that. I think something to keep in mind is it actually does less harm to get it all out at one time. Formal disclosure, like let's talk about it, let's address it, let's just get it out versus I'm telling you a little bit and then maybe a week later I tell you a little bit more and then maybe a year later you find out a little bit more. It's that does way more harm than like
Yeah.
let's just address it head on and talk about it. And I think it can feel really scary, but it actually is what is researched and recommended when
Yeah.
affairs are happening.
Yeah. And I love that you brought that up because, yes, it is much more effective, much more repairable to
Yeah.
put it all out on the table at the beginning than to put a little bit out. We do some repair work and then more comes out because every time a little bit more comes out, it's re injuring that wound. And at some
Yeah.
point, we're not going to be able to repair that. Like at some point, the wound is going to be too deep, it's going to be too nasty and gnarly. Like nobody's going to be able to repair that. And so
Yeah.
if you're wanting to give the relationship a shot at all, put it all out at the beginning,
Yeah.
And I think too, one thing that popped up in my head when you were talking is I know sometimes we have couples come in where maybe the partner that's like actively using or actively in an affair thinks that we're not going to know it's happening, even if it hasn't been disclosed. And we're going to know because again, we're going to keep hitting that wall. And so
Yeah.
it might take a couple months for us to figure out what that block is or what that competing attachment is, especially if nobody's talking about it. But it happens every single time because at some point, we hit the wall and it's like, okay, what's stopping us from making progress?
What is missing here?
Right. And then we're at what you said, we've been doing all of this work and now this big bomb is going to come out when it would be much more effective and clinically appropriate and research backed to just put it out there in the beginning.
Yeah, totally. And I don't also want that to scare anyone away. Like, say the
Mhm.
latter has happened, where it's like an affair has happened and it's been years of this information coming out in like little bits and pieces. It is absolutely still possible to
Yes.
do the work and heal and come out the other side of that strong. But I think that takes a really big commitment from both people. Like we are going into this process open-minded, and I
Mhm.
think open-minded and trusting in the therapy process, which I think is really hard sometimes in couples, especially in the beginning, because it
Yeah.
feels worse before it feels better. Like we're talking about
Yeah.
hard. We're having, you guys do things and speak to each other in ways that you wouldn't normally. And that's the point. And it feels weird. And your nervous system is like, what is my therapist having me do? This feels like not my normal, but that's the point. Like we are trying to
For
create
sure.
new patterns here. And so I think don't be afraid if there is that, if you have experienced that where there's been like these little ruptures, like kind of like a little bit of healing, we're ripping the scab off again. It's a gross example, but that's where my brain
Yeah.
goes.
But it's perfect.
With like the mini disclosures.
Yeah.
You can still absolutely come to therapy and do the work, but both people come to therapy and be ready to do the work and be open to the process, I think.
Yeah. Well, and I find, and I'm curious if this has been your experience too, but I find that if there is kind of this hidden addiction or affair, usually the person who has been injured in all of that already has this like kind of like gut inner knowing that something else is going on. So a lot of the time it's like, it might be initially shocking, but then, as we're processing and as we're doing a lot of the intensive repair, I frequently will have clients that are like, my gut told me something was up and I wish I would have listened to it.
Uh,
I think I knew that.
Totally. Yeah. I think, yeah, if we slow down enough and tune in enough, the gut is speaking always. Your nervous system is paying attention
Always.
to everything. I think something that can be problematic when affairs are in the picture, or I mean, not even just affairs, but like secrecy. There is something
Yeah.
that is like that happening that we are like, one partner is maybe keeping to themselves. I think as a therapist, you have to be really cognizant of that. I mean, we have a policy, like a no secrets policy in
Yeah.
our work that basically says, like, we're not going to keep secrets for you. Like, as the couples therapist, we're working for the couple. We're not working for one of you specifically. And so if something comes out or comes, to our attention that there is something secretive
Hmm.
happening, like an affair or an active addiction, and you're trying to keep that from your partner, we will find a way to bring that up all together in
Yeah.
session because it's not our job to keep that secret. And it's actually doing a lot more harm because then you're actually triangulating. Now, therapist is then triangulated in
Yep.
this like lack of trust situation, which can be really, really damaging for the other person, for all
Hmm.
parties, actually. So that's something
Right.
that came to my mind too, because I feel like that is maybe more prevalent when there is like affair secrecy happening, and why, like, another reason why, just kind of like, let's get it out. Like, if we're going to do the work, we need to just start from like this honest slate, everybody be on the same page.
Yeah, no, for sure. And I think too, you talked about triangulating the therapist in. And if we know that something is happening, like let's say we do the individual session, a partner discloses, like, yes, I'm seeing this person from work. I don't know, I'm just making stuff up.
Yeah.
It's not like we're going to be like, other partner, your partner just disclosed that they're seeing somebody from work. Like, we're not going to go and like
Oh,
tattle
no.
on them at all. Like, it isn't like that. It's more of, okay, this needs to come out. So, how do we want to structure that and present that in a way that can be honest, can be open, and can give us the best chance for healing? And so, a lot of times we will work with the person who maybe is having the secret or the hurtful behavior of, okay, how do you think you can communicate this? And there are some that are like, I'm not going to. And it's like, okay, well, if you're not going to do it, I'm going to do it in the next session. But usually that's if there's like so much resistance or
Yeah,
like denial, anger, like things like that, where it's like, this has to come out because, again, going back to your initial comment of like safety trumps everything else. And
yeah,
so if this is a safety concern in the relationship, we need to put it out there. The sooner, the better.
totally. Yeah, and I think sometimes that you had said this, like working with the individual who's maybe like
Mhm.
doing the affair on a way to kind of get that information out that feels safe. I think something else that we can do is coordinate care with, say, this individual is also seeing like an individual therapist.
Yeah.
That's why, like, releases of information, I mean, this is one of the many reasons, but why releases of information so that we can coordinate care with, like, individual counselors and things like that can be really, really useful because it's like, okay, maybe that is, like, we're making a plan all together where this feels like, you're really scared to do this thing, but we're gonna do it in a way that feels like, "Okay, I can do this, and I'm empowered to do
Yeah.
this." And that can be helpful too in, like, their individual work to get to that place of feeling like they can, I guess, disclose what is
Hmm.
actually happening.
Yeah.
Yeah, and the thing that, like, for some reason comes up again in my brain, I kind of already said this, but how important that the therapist isn't, getting triangulated into that like, process of secrecy because thinking about that other person and they're now getting kind of like betrayed by two people, it feels like to them. This person
Yeah.
is betraying me, and now like this therapist who I'm trusting and wanting safety from has this like secret that they're keeping about my partner, like that feels like a
Yeah.
massive betrayal. So it's just something that we're like very, very aware of and do
Mhm.
a lot of assessment for and try to do it in a very careful way.
Well, and even in that example, we would ruin our therapeutic relationship with the client, but also any future therapeutic relationship because we are basically going to injure the client from therapist as a
Yeah.
whole.
Oh,
They
yeah.
kept a secret. I don't ever want to go back. They suck. They're horrible. It's like such a huge injury. And so we might be willing to sit on it for a short period of time where we're trying to figure out and like come up with a plan of like how to do this disclosure. And that might even be talking to the other partner, like if they're in individual therapy, like are they at a space and resourced enough to hear this? Because if this is going to come out, especially if there's any sort of like, I don't know, like trauma history where it's going to really trigger them from like childhood or a past relationship, or if there was addiction or like self harm, eating disorders, depression, we
Yeah.
also want to make sure that like both partners can have that conversation. And so it might be a delay in doing the disclosure, but we're not just going to like kick it down the road for a year and say, okay, well, we're never going to talk about it because, again, we're going to hit that wall.
Yep. Yeah, and I think it all like, something that I'll talk about with clients is, like, what you guys are here in couples therapy for a reason. Like, you're
Mhm,
here like, being here tells me that there is a part of you somewhere in there that wants to save this relationship,
mhm.
get closer, regrow trust, whatever
Yeah.
those goals are. And so I think, like, really empowering maybe the person who has engaged in the affair of, like, what is it that you're wanting? Like, if you are really unwilling to, you know,
Mhm.
have that disclosure and come from this place of honesty, then let's talk about like priorities and goals, because we literally can't do couples therapy when there is this active
Mhm.
lie sitting in the room.
Yeah.
Everybody will feel that, and the wall will just get hit over and over and over and over again. So it's like, what do we want? Kind of
Mhm.
rip the band-aid off and like, yeah, it's hard, it's difficult, the conversations are difficult, and that's where the most growth can come. And the
Yeah.
most trust is like, let's just peel it back and have really raw, honest conversations about it.
Yeah. Well, and one thing that popped up for me when you were talking about it, and I'm switching gears just a little bit, but I think another contraindication, whether it be couples or family therapy, is if one partner or member of the family is maybe unwilling to follow like therapeutic guidance, or maybe unwilling to look at their part, or are so close-minded that they don't want to look at like their part of the problem or take accountability, do an apology, whether that's who knows. I mean, it could be like undiagnosed mental health, it could be, something else that's been going on. But at that point, it's like clinically and ethically, like this session, if we were to continue therapy, is going to cause more harm for everybody involved. And sometimes with affairs, there might be somebody that comes in who's like, I don't love my partner. I don't want to be in this. Like, I'm in it because we have kids and like, I don't want to separate the family, but like, I'm out. And so, even in situations like that, where maybe one partner isn't fully in on healing, or maybe they're 100% out on healing or repairing, that would be another contraindication too.
Yeah. No, I like that you said that. And it's never about like, always client autonomy, like make your own decisions for yourself, of
Yeah.
course. But I think it goes back to that question of like, why are you in therapy? If there is no room for openness to what to what the therapist is saying
Yeah.
and guiding. And these aren't like, you have to go do this thing, but it's like, if there is this, refuse to do an apology. I refuse to have a conversation about this thing with zero space to kind of get in there. Again, it'll be this wall being hit where it's like we can only
Yeah.
do so much at that point.
Yeah. Yeah.
Because it really has to be an active process for everybody.
Yeah.
And if one client is engaged, one client
Yeah.
isn't, excuse me, it's again hitting that wall.
Yeah. And it's not like everybody has to be 100% in, because realistically, like that typically does not happen, especially with like couples and families.
Yeah.
There's always one party that is maybe less open or maybe
Yeah.
less trusting of the process. And I will often ask clients, like, give me a percentage of how much of you is in this and like willing to do the work and be open, and how much of you is out. Because even if there's like 1% that's willing, like that's enough for us to get in and like do some
Totally.
progress. But if they're like, I'm 100% done with this marriage or this relationship, then our conversation looks like, okay, so what would be helpful for you guys? Is there any chance of repairing and changing your mind? Or do we talk about what that process looks like? What does that look like? Because we do have that clinical and ethical obligation to make sure that we are we have a treatment plan in place, it's clinically appropriate, we're working towards goals, and that the session isn't going to cause harm,
Yeah.
or even in families. So
I love that you brought up the percentage thing. Like, it does not need to be the wide open door. Like, I talk about that sometimes. Is like,
Mhm.
it doesn't have to be this, like, I'm 100% in. My door is wide open for this. Is it cracked? Even just a tiny hair? Is it closed, but it's unlocked? Or is this like slammed shut, locked?
Like Fort Knox, like it's not opening.
Yeah, 2 feet out of this relationship. That's different. But
Yeah.
yeah, even that 1%, like absolutely. And I think something I want to say too, as hearing you talk about that, is I think part of the therapy process can be getting that door, getting
Yeah.
that percentage to move. And so it's not always like in the beginning, say one partner is like the one who's pushing therapy, the other partner is like out the door. It doesn't necessarily mean, okay, well, we can't do the work because
Exactly.
one person is at like a 50. It might, maybe some of that beginning work is like, what would it exploring? Like, what would need to happen? What would look different if your 0 was a 1? Like, what are some things you would notice? Okay,
Mhm.
let's talk about that. Like, that beginning work might be just exploring some of that stuff and how to
Yeah.
explore a little bit.
And it might even be, how did you get to a 0? Like, what are those things that led to this place? Because that might even, just having the conversation might be enough to shift the door open just a little bit, or, give us kind of a roadmap of, okay, there have been some really big injuries, so we need to do some repair work. And it might be too that that's when we make that recommendation for an individual therapist. Maybe there's some traumas that have come up and it's like, go work on that. Or, maybe the partner who is like maybe 1% open, maybe they hit like a major depressive episode for whatever reason, whether it's like situational, maybe it's hormonal, maybe it's something. So even in that, we're going to be looking at, okay, what are those biological factors that could also be contributing to this? And would you be open and willing to meet with your primary care doc or see a psychiatrist or talk about it? What are you doing to work on these factors that could be stopping you from connecting with your partner?
Yeah. I feel like this conversation just reminds me how much I love being like a systems-based therapist because like we think about really all of the things and all of the systems, like not just like systems of people, but the biopsychosocial, like what is
Yeah.
happening. I feel like that's something that's like always primed in our brains during assessment. That is a huge piece of the puzzle. So I don't know.
Yeah.
That was just my systems therapist over here.
I love it. Well, and I think there's more and more of that coming up. And I think we've talked about this a little bit on some other episodes, but there's more and more research coming out about like female aging and like perimenopause and like mood shifts
Yeah,
and hormonal shifts and things like that, where it's like divorce and perimenopause is on the rise. ADHD, depression, anxiety diagnoses, and perimenopause are on the rise because it's like the resources that the female had with all their hormones kind of at a good level, they don't have it anymore. And so even looking at that, like we would do a disservice to a couple if we were like, okay, you want to get divorced, like good luck, peace out, here's some lawyers. If we didn't bring up like, have you thought about getting like full lab work? Like, where are you
yeah,
at? When did this change? How did you get here? And so helping them kind of piece things together. And I do want to say for some couples, like we're going to do that work and the relationship still might end because the partner might be out. Like there might have been, they might have hit a point of no return that they were willing to show up, but like there was no way for us to put it back together, depending on where one or both partners are. And so there is that chance, but that isn't something that we come into couples or family therapy thinking, this is going to be a disaster and we're not going to be able to do anything. We're always going to be putting in just as much work, if not more, than what our clients are to help them heal, to help the relationship heal, to help the relationship be secure.
totally. Yeah.
Yeah. I
Yeah,
feel like,
there's just so much that contributes to so many things. And sometimes, like, we don't realize. Like, I mean, I think that's everybody. Like, sometimes having that just like, okay, I think the blood work piece, the lab work piece is something that we talk about a lot. And I feel like it's
Mhm.
so in that early assessment. Anytime I get a feeling that like maybe there's something else potentially like happening here. Okay,
Yeah.
well, last time, like, let's just touch base, not in like a shameful way, but
No, but curious.
I'm and like maybe this would be helpful and like, are you open to that?
Mhm. Well, and yeah, and I was just going to say it's interesting because, I did my grad school in California. So California MFTs are trained a little bit differently, not better or worse, just California has they have different, I guess, like ethical guidelines in terms of, if there is a depression, the first step should be this is drilled into me.
Yeah.
Go get blood work, meet with a doctor before, we like recommend antidepressants or things like that. Like rule out any sort of biological component or physiological component that could be leading to this thing. And so I think that's something our practice does as a whole, where it's like, we don't want to just like treat the symptom. We want to get to the root of what it is. And so if it's the biological component, the biopsychosocial, or if there is some outside thing like those contraindications that we've been talking about, it's like we need to get to the root of that so that we can give the system, the individuals, a chance to heal in the correct way, where we're not just like putting band-aids on things where those wounds are going to open up later.
Yeah. No, I love that.
Yeah. I feel like we could do like 5 episodes on this because I'm also thinking of like mental health contraindications.
Podcast. We get
I
going.
know.
Okay. Probably do 6 more sub episodes of this. And maybe,
Totally.
but yeah, there is so much. Like we touched it barely, but like scope of practice, mental health, certain mental health things. Maybe we do a pinned episode later on.
We should do that. And it would be fun, like if you and I did it, or even like if we had other people from the practice in, because I would be curious their kind of thoughts and takeaways, because I feel like we're all really similar in it, but I know we all have a little bit of a different kind of specialty or like kind of like client population that comes in. And so I think it would be interesting to hear too from other people. Wow. But I'm so glad we got to do this today. I always have fun with you. So thank you for doing this with me.